She's a certified nurse midwife with a doctorate in public health, specializing in maternal health system strengthening and quality improvement. Since joining the Women and Health Initiative in 2013, her role has included in coordinating the efforts of the WHO-led Ending Preventable Maternal Mortality Working Group to develop the global policy paper, which is called Strategies Towards Ending Preventable Maternal Mortality, and to the UN Secretary General's updated global strategy for every woman, child, and adolescent. So Rima, welcome, and I hand it over to you.
Thank you. Thank you very much for this opportunity to moderate this illustrious panel and be part of this great day. It's really, as Petra has said, I'm echoing her words, it's just really special to be here in this room with so many mentors and friends and champions for maternal health. And so what a great day. Well, this is a formidable baton pass from the last panel. So we are going to take the lessons and the richness of what we heard of describing the last 30 years, and we're going to do our best to be future-facing and action-oriented and hopefully bridge those lessons learned and translate them for a changed world and look at what's the same and what's not the same and what we can do. So our panelists, we have a really great panel, and as it happens, their talks are going to follow along a little bit on the levels of the health system, that if those of you who know Donald Berwick's model from the Institute of Medicine, where you start with women-centered and the microsystems that serve them, so that true north, the foundation, the women we serve and the people who serve them, whom many of us are women, right? And then those systems and that provide the care, and then those macro level issues of policy, so, and laws and social and cultural context. So with that, I would like to start by introducing our first speaker on the panel. Adres Malata is the Vice Chancellor of the Malawi University of Science and Technology. She is also the former Vice President of the International Confederation of Midwives and the former Principal of Kamuzu College of Nursing, which is a constituent college of the University of Malawi, and spearheaded its development into a World Health Organization collaborating center in 2016. Adres is a renowned international speaker, author, and editor of various journals in the field of health and science. She serves on various international, regional, and national boards. And she's also, I think most importantly for us today, a staunch advocate for girls' and women's empowerment through education and health. So with that, I'm going to pass the microphone to Adres. We're lucky to have you. Thanks.
Good afternoon. I want to sincerely thank the organizers for inviting me to this important event. And I'll be speaking from my heart. And the reasons why I'm doing so is because I'm a midwife and I love women, I love mothers, I love children. But more importantly, I believe that 30 years of safe motherhood, we need to start looking into the future. And we need to look at what can we do to save mothers' lives, and from my context where women and mothers are still dying whilst giving life. My presentation, I'll look at some priority areas as well as game changers and challenges that we've faced as a country, and also speaking for other low-resource-setting countries. I want to start my presentation with a personal experience of a woman who died in Malawi. The mother told me the story, which broke my heart, and that makes me think about our celebration today, to say, is it really that we have done much for our women? Have we made a difference for our women? This woman came to a facility in Malawi, pregnant, and she stayed in that facility for 48 hours because she had prolonged labor. There was no transport to take her to a facility. And she to go to a district hospital for operation. She needed cesarean birth. She waited for 48 hours with her mother, went into a district hospital where she died on arrival. So her mother said to me, my daughter and myself waited for 48 hours, 2 days before an ambulance came. But when my daughter died on arrival, within a short time, the midwife came back to me to tell me that there was transport to take my daughter back. And this was now a dead body. And she asked me, this mother, that why was it that we waited for 2 days before my daughter was transferred to a district hospital, but only took a short time to take my daughter back home, and this time she was dead. My life has never been the same, because I've been thinking 3 decades of safe motherhood, women still die, and they die preventable deaths. This story has changed my life and has given me that impotence and energy to move on and to do all I can, not just as a leader, but as a midwife and also as a mother, to save women's lives. If you look at our context as a country, Malawi, and you can see the figures there, progress has been made. Maternal mortality ratio has reduced. At least now we are just above 400 per 100,000 live births. And I take that indicator only for this discussion and for several reasons. Many years ago, we were at over 1,000, and today we can celebrate. But can we really celebrate 400 women dying out of 100,000 live births? I don't think it is good enough. And I don't think that we should be sitting thinking that we have made adequate progress. I don't think there's anything for me really to celebrate. 400,000 women is not a small number. It's a big number. It means in Malawi every day some women die whilst giving life. We have a program goal. So we would like to see improved sexual and reproductive health for all men. So men are included in Malawi now, women, young people, but more specifically for the vulnerable and underserved. Some of our activities, and I do not want to labor you because you know all this, that we have our Safe Motherhood Initiative, more specifically, I think, launched in 1998, although there were activities before that. But as a country, Malawi moved on to what we called sector-wide approach and plan of work for the health sector strategic plan. We also moved on to a roadmap for reduction of maternal and newborn mortality. So this has been a major initiative in Malawi, focused on antenatal care. All these other initiatives that I think have already been discussed this afternoon. A lot of activities, building maternity waiting homes, community-based interventions, family planning. All these activities have been launched over the past few years, and I would say the 3 decades. And as I said earlier on, yes, reduction in maternal mortality, and you can see the graphs that I'm showing you now. But at the end of the day, the question is this good enough progress? And I'm also putting there neonatal mortality because we would want to see every woman that goes back home with a live baby and that baby lives on. And I like the question about stillbirths that came up earlier on, because many of these women too go back home and they have lost those babies, and no one talks about it. And particularly in our culture, you don't want to talk about a stillbirth. And yet these women are traumatized for I think, as long as they live. This is information that we all need to bear in mind. And I do know that the focus on maternal mortality at a certain point in our country actually ignored neonates. But at the moment, we've said, no, you talk about the mother, talk about the neonate, because we want to make sure that that woman survives. What are the major challenges? And I'm picking just a few things, more particularly for quantity and quality of midwives. Malawi still has a challenge. very few midwives. And we're talking about competences here. Is a midwife able to provide care? Not only for Malawi, but many low-resource countries have got a similar problem. So we have looked at issues of education, regulation, perhaps even strengthening the associations in our countries. Many countries in Africa do not have midwifery that's regulated, and it is doctors that are teaching midwives. So as we celebrate, I think let's look at these issues that if we do not address them, and many times are swept under the carpet, our women will still die. Because we want a midwife who, if they say they have graduated, they should provide that care, give that care with all compassion, but also with the right competences. I also want to say that there are issues with faculty. So we have faculty that are not prepared, that don't have even a career pathway, that if we do not address their issues, they normally will leave teaching. And so many of you here are from international organizations, and I lost many of my teachers, either working for USAID and UNFPA, but it's okay. They are giving care to women in one way or the other. But at the end of the day, we also want to keep good midwives in the schools that can teach well. I think, outlined a few issues in that slide, but not to labor you, just to say that in teaching midwives in many of these countries, we have issues with curriculum overload, because every program that comes into the country, their target is a midwife. So if it's malaria, okay, let's go to the midwives. HIV, midwives. Maybe there's another issue about maybe a new development, midwives. At the end of the day, midwives are not learning the skills. They are learning all these other issues, and they are not competent. And I think as an advocate for midwifery, I would like to start protecting the profession. We should be able to say, no, they will learn this later on, or perhaps just elements, but let's not do these things at the expense of quality midwifery care. And of course, the issue of, do they have adequate time to practice when they are going through a midwifery program? I would not labor with you that slide, just to show you that we do not have adequate number of health workers, and more particularly midwives. What other challenges do we meet? The other challenges, when you look at our countries, you look at the issue of resources, drugs, infrastructure. These are issues that can address these problems. And it's very sad many times when you have partners that want to support maternal health care, you raise these issues, they will say, no, in our program, no infrastructure. We can only support this element. Now listen to that voice. If you don't want women to die, then listen to the people that are on the ground. They are saying they need infrastructure. Give them the infrastructure. But if you do not respond to the issues they are raising, many times you find that there's so much money going into maternal health. And if you look at the figures are huge. But why are women still dying? We are not addressing the core issues that can change women's lives. And I also want to point the issue of quality of care. It is not just about women coming into facilities. Do they get the quality of care that they deserve? So quality, equity, dignity, as shared earlier on by Betsy, are issues that need attention. What can change the game? Political will and leadership. And I thank God for Malawi, all our presidents, their wives, their spouses, have been very committed to maternal and newborn health care. A lot of initiatives in Malawi, President Banda, President Mutalika, and First Ladies, the two First Ladies that we have really committed to maternal and newborn health care. And that's, to me, something that can really change landscape for safe motherhood. But we also need to be looking at issues of accountability. So at the end of the day, as I said, a lot of resources. Can we account for the money that's coming into our countries? Educational midwives have talked about that. Enabling environment, collaboration and partnerships, very critical. And of course, active role of civil society. And I want to thank White Ribbon Alliance. They have really been an advocate for midwifery. That's what we want to see. We need to invest for innovation. And of course, evidence, evidence, evidence. Lancet series for midwifery, I think my colleague here knows I was one of the authors. We did actually help countries to understand that there's evidence for what we're talking about. So we need to push for that. And of course, we need more advocacy for maternal and newborn health care. And as I finish, multi-sectoral approach to safe motherhood is something we need to push. I'm not talking about lip service here, because many times we talk about multi-sectoral approach, but everybody's doing their own thing. I want the reality, and I think this lady, who is former commission chairperson for African Union, Nkosazana Zuma, emphasizes the importance of multi-sectoral approach to safe motherhood. And I do know that we all talk about it, but less is done on the ground. Finally, I do know that we've made progress, not only Malawi, many other countries have made progress, but we also know that we still have to work hard to ensure that women do not die. Women are still dying. And I do know it's very easy many times to look at some figures, maybe somewhere where perhaps things seem to be improving, but I want to say to you, from my point of view, and coming from that grassroots level, women are still dying whilst giving life. And we need to work hard so that they do not die. And my dream, and I think some of you know, is about if your dreams don't scare you, they're not big enough. So my dream for safe motherhood is no woman should die. And it's a big dream when we're talking about 400 women, but no one should die. It is scary, but it can be done. And I think all of us sitting here this afternoon should have that push that no woman should die. And let's do our part in our own opportunity. Whatever we can do, our contribution should be to that woman in that rural area who may not have a voice, may not come to here to Washington, but they are there in a rural area. What can we do for them so they survive? Thank you very much for your attention.
Thank you so much, Address, for those remarks. And I'd like to take just a few minutes to go a little deeper and ask you a few questions about that, because you have such a special perspective. You bring both the depth in Malawi and also the breadth across, you know, in your role as the former vice president for the ICM. So I'd like to ask you, you've highlighted how increasing the number of competent practicing midwives will be critical to achieving that dream, that big dream. And so I wonder what you would say, because you mentioned a lot of different influences, and what would you say is the number one barrier at country level to achieving that goal of enough midwives to make sure that all women have the right care?
Yeah, I think it's okay, thank you. I think the number one barrier is really lack of investment into midwifery, education, regulation, and of course practice. As I said earlier on, a lot of lip service, I must say, in my experience the past 30 years, where people talk about midwifery, midwives, not only in Malawi, but international fora, where everybody is advocating for midwifery, but at the end of the day, when you ask, how much are you doing for midwives to ensure that they are properly educated, very little is being done. No resources for teachers, no resources for teaching and learning. And sometimes even midwives that are there sitting in a school without fees, because they have to pay fees. And even later on, investment not only for education, but also retention. Because you can educate midwives, but at the end of the day, they need water, they need electricity, they need a house. And they are sent to rural areas, and who doesn't want their child to go to a good school? And we all forget about this. Everyone thinks they can go anywhere without any proper conditions and think they'll stay there. They will not stay. Even if they were so committed, they are overwhelmed, they are overworked, and there's not much discussion about that. And in Malawi, so much discussion about medical doctors. So my daughter is doing medicine now, and I can already see a future for her. whilst my own midwifery students will be finishing, and there's no house, there's no electricity sometimes. And as I said, we need to listen to these voices. Can we keep these good midwives in these rural areas so they can provide care? If you do not provide for them, they would go to that rural area and they'll stay 1 year. They want to get married, they have now children, they want to go to a place where they can send their child to a good school. So my message is, let's invest in midwifery education, retention of midwives, so that we can improve quality of care.
That's great, and I'm just going to push a little bit further. I love that answer, and I wonder, and of course, none of us have the answer yet. We're working on them together. But if money and material resources were no barrier, so if somebody said, okay, we're giving you what you just asked for, we're going to invest in midwifery, as we do believe you that is the answer, what's the first thing that that you would do in Malawi? And then perhaps, do you think that's applicable, or is it so context specific that would be what you would do in Malawi would not extend to other contexts? But if somebody gave you a big pot of money, what's the first thing that you would do to meet that goal in Malawi?
So if the money is for midwifery education, then I would build more schools and then make sure that I have adequate teachers that are properly trained themselves, because we have nurses teaching midwives as well in many schools. But really have a card of midwifery educators that have got competences, that are confident and can teach those midwives. And that all requires money. So you need to invest in programs for midwifery education, and of course making sure that there are resources for teaching. So when a student is in that school, they can go into a laboratory and find equipment. The reason why I said build more schools is, as I said earlier on, in my role, actually, when I did the College of Nursing and Midwifery in Malawi, every time I asked for resources for infrastructure, many of the partners said, we don't invest in infrastructure. But we can give you scholarships for more students. So we ended up taking more students, and yet no infrastructure. So I do think that probably the investment is not just about scholarships. It is about both infrastructure and other teaching and learning resources that any country would need. But as I said, we can't talk about midwives in isolation. They need proper environment. So the hospitals and the rural areas where they're working, there has to be proper infrastructure, transport. I mean, the story I talked about, there was no ambulance. And even if the midwife was good enough and she has identified a problem, but they have to wait for 48 hours, then they still feel frustrated, because at the end of the day, when these women die, midwives also get overwhelmed, and they start, feeling perhaps I'm not doing the best I'm doing for my clients. So it is beyond educating midwives. It is also looking at the environment, their career pathway. I personally, I trained in Australia for both master's and PhD, but when I went back to Malawi, one thing I wanted to do was to introduce programs in Malawi for postgraduate programs for midwives, even at PhD level. So Malawi has got a doctoral program in midwifery. And the reason I did this is because for me, I had to leave Malawi with a 10-month-old baby to pursue a PhD program in Australia. I did not want that to happen to all midwives. So I thought, well, others will want to go to the US, to Australia, but I wanted those midwives who wanted to study in Malawi, stay in Malawi. And so we have masters in midwifery in Malawi. There's a PhD program in midwifery. And the reason is because it is very difficult to leave your family. And I know others like it, but not everyone likes it. And for me, I went through a lot. Two-years-old baby in Malawi, 10-month-old baby with me in Australia. So for me, as a leader, I thought I should not allow other midwives to go through this. Let's have programs within Malawi so people can have a career pathway. If you don't have career pathway, people will leave. They will leave the profession and go into another profession, because, I mean, the young people of today want to progress. Thank you.
Thank you. And I think you've given us a really good sort of action plan for midwifery. I heard you talk about ensuring a pipeline that's not, that teachers who can teach all the competencies, but even, postgraduate work to ensure that the young midwives have mentorship waiting for them and adequate education, but also that enabling environment through infrastructure and so forth. Is there anything you would add as the action step, the action plan for the future? Now that they've passed the baton to us from the last panel?
Yes, so I think that the other issue I want to talk about is girl education. And I do know that we talked about boys as well, and of course boys too, because we have in Malawi male midwives. But I do believe that we need to get every girl to go to school. Not just going to school, but staying in school. Because the moment they are well educated, they can make decisions for themselves. They do not have to wait for an uncle to decide whether they should go into a hospital or not. This issue of girl education, although we talk about it, but the reality on the ground is that there are still girls out there that do not go to school. If they go to school, they'll stay in school for a few years and they drop off. And not always to get married, but because they do not have that encouragement to stay on. And also the environment in schools does not promote the girl to stay in school. Many countries in Africa have challenges with girl-child education. And I do know that when you look at figures, it looks like we're making progress. But if you go into any country in Africa, you will find that girl that should have gone to school that is still at home, or perhaps they get married early. And I think that's something we need to invest in, but not forgetting the boy child. Because at the end of the day, if she gets pregnant, who is responsible would actually be another boy. Thank you.
Great, and I'm going to now introduce our next panelist, who is Dorothy Lazaro. Dorothy is a registered midwife since 1981, also a registered nurse and a public health nurse. She is an experienced midwife who has worked across a lot of sectors with government agencies like Save the Children and the United Nations Population Fund. She's actively contributed to the development of maternal and neonatal health programs in Malawi and Ethiopia, and actively participated in the development and implementation of the national roadmap for accelerating the reduction of maternal morbidity and mortality and the sexual and reproductive health strategies of Malawi and Ethiopia. She's been working for the UNFPA for the last 21 years, and with a special focus on maternal health across the areas of sexual and reproductive health. And she's assisted the government in training, to address this point, 4,700 midwives, 305 emergency surgical officers, and 220 nurse anesthetists. So without further ado, I pass you the microphone.
Thank you, Rima, and thank you, the organizers, for inviting me to this meeting. It's a pleasure to be here among professionals. And I've also been working in the hospital for a long time, just like Address, and I know what it means losing a mother. When a mother dies in your hands, you'll never forget that experience. You can forget some deaths, somebody dying with tuberculosis, somebody dying with malaria, but when a mother dies in labor ward, it always remains in your mind. But I would like to come and talk about the case of Ethiopia. I am talking, unlike my friend Address from Malawi, I would like to bring more hope. For me, I'm seeing more hope for Ethiopia. So I just want to share that experience of hope. That is the map of Ethiopia. Ethiopia is in the Horn of Africa. It's a very large country. It has 11 regions, and they're very different. You think a region is a country on its own because the culture is different, the language is different, the topography is different. So it has its own challenges. I would like to compare the indicators of 2008, the maternal health indicators of 2008 and 2016. As I already mentioned, Ethiopia is very, very large. As of now, we have an estimated population of 102 million. And our maternal mortality ratio is just like Malawi. We are at 412 per 100,000. But it has reduced from 673 And before that, it was over even 1,000. So we are still looking at it positively, and we believe we are on the right track. The infant mortality rate has also reduced to 48. The same with the neonatal mortality ratio. It also has reduced to 29. However, we have still challenges with the skilled birth attendants, as only 28% of our mothers are delivering in the health facility. Of course, that is from the DHS, but you get different figures. From the Health Management Information System, they will give a figure of 70. And recently we had an emergency obstetric care assessment, which was actually a census of every mother who delivered in the hospital, and they came with a figure of 66. So the government believes the figure of 66. But in the area of contraceptive prevalence rate, we think we are doing very well, because now we are at 35%. We rose from 14%. But we still have a higher unmet need at 22%. That also has dropped, but we still need to work more in that area. So what did we do as a country? In 2008, we had a serious shortage of human resource. And when I say serious, I mean serious shortage. We didn't have enough doctors, midwives, nurses. We really had a serious shortage. So we decided to expand midwifery training institution. As of now, Ethiopia has over 50 institutions that are training midwives. The government invested highly in that area. Not only the government, UNFPA and USAID also invested in training of midwives. In the past 10 years, we have trained over 10,000 midwives. Now our current figure of midwives trained is 12,000, but 4,400 of them has been trained with the support of UNFPA, with funding from SIDA. We have also worked so hard to strengthen the Midwife Association. When I went to Ethiopia in 2008, the Midwifery Association was very, very weak. They only had 3 staff in the association, but we worked with them, we trained them in resource mobilization, trained them in the, project management, in strategic planning. Now they have 35 staff that is working with them. And most of the trainings that are conducted by, that are supposed to be conducted by government these days, they're given to the associations. They are the ones who are doing those training. So we have provided a lot of teaching and learning materials in our midwifery training institutions, and we have a lot of midwives, students who are currently under training. The other area we looked at was to look at issues of maternal health as a team approach. So not only training midwives, but also training emergency surgical officers who are providing emergency obstetric care in primary health hospitals. And UNFPA with government started that program, and we started in 5 universities and trained nurses and nurses and health officers who were trained at a BSc level. We gave them a 3-year training in task shifting, and they are now doing emergency obstetric care in the hospitals. And we have been following them, and the results are very good, because where they have been posted, there have been a 40% increase in the number of deliveries, and also a reduction of institutional maternal death. Apart from that, we also had to train nurse anesthetists, because we realized that if there's a nurse, then there's somebody to do cesarean section, but if there's no somebody to provide anesthesia, then we cannot make any progress. So we also trained over 220 nurse anesthetists so that they can also give anesthesia. But apart from that, the government has the Health Extension Workers Program that has recruited 38,000. Oh, I'm just talking. Sorry. Nobody reminded me. Yeah, we have also a Health Extension Workers Program that are 38,000 health extension workers that are deployed in 16,000 health posts. And they provide various sexual and reproductive health services, including family planning. So as I said earlier on, those are some of the midwives that we have been training, and those are the numbers. By 2008, we only had 1,275 midwives, but now we have 12,000, and 4,000 of them have been trained with support from UNFPA. So the other thing that the government did was to expand health facilities. There has been a massive expansion of construction of health facilities. In the past 10 years, they constructed 316 hospitals. And these are both government and private hospitals. And the government also constructed 3,600 health centers. And all the nurses that we have trained under the UNFPA program, they have been deployed in these health centers. And we have also seen that the availability of basic emergency obstetric care has increased, but slightly from 4% in 2008 to 30% now. And there has also been the construction of the 16,000 health facilities. But apart from that, there has also been expansion of family planning services. The health extension workers are providing family planning services in the rural community. They do a lot of giving information. They even insert implant at the community level, but for removal, they have to send the woman to the hospital. And apart from that, now we are training them to insert IUCD. And we have seen that in Ethiopia, 60% of our mothers who are using family planning, they get it from the health extension workers. We have also constructed a lot of maternity waiting homes. As I said, the topography is very difficult in Ethiopia. So many areas are very hard to reach. But as of now, it is a must that every region and every health facility should have a maternity waiting home where a woman can go and wait for delivery. And it's only one region so far that do not have a maternity waiting home. So this has helped the mothers to receive care in the health facility. But we still have challenges that are remaining. We still have low coverage of emergency obstetric and neonatal care at 40%. The services are also not very good. We still have poor quality of care. And we also have disparities in utilization within the regions. Like when you see on the graph there, you have regions where they have 100% coverage. At the same time, you have other regions with only 12% of coverage. And we still have high turnover of staff and issues of some of the facilities. Although they are there, they may not have electricity and they may not have water. The issues of inequality are very, very challenging in our country, and this is one of the priorities of the government that is tackling now, because when you look at all the indicators, you will see that there's very huge disparities between the regions, not only in the area of maternal health, but in all areas, family planning, antenatal, skilled birth attendant. You see that there are huge differences between the regions. Thank you so much.
Thank you, Dorothy, for a wonderful presentation. And again, we're lucky to have your both depth in the experiences in Malawi and Ethiopia, and then the breadth of your experience of 21 years with UNFPA. So what I'm really fascinated or curious about is your presentation really highlighted Ethiopia's focus on a range of upstream health system strengthening strategies, from focusing on workforce development, availability of infrastructure facilities that Edras had pointed out as a need, demand creation, unmet need for, addressing unmet need for contraception, and then equity. And that was the strategy that's been used to increase the downstream coverage of key interventions like those indicators that you showed us, the SBA and the antenatal care coverage, in order to reduce mortality. So I'm wondering, from your perspective over these years, what is the right balance between those proximal, quality of care, clinical interventions, and those upstream health system strengthening strategies in high-burden countries to end preventable maternal and newborn deaths by 2030? What's the best mix, and how do countries make those decisions about what to focus on?
Thank you for that question. Countries are at different stages, so it cannot be one size fits all. But there are similarities between the countries. You see that most of the countries that are high-burden countries, they have so many things in common. Mm-hmm. So for me, I'm thinking that in terms of balance of the strategies, the first strategy that we need to focus on as countries is the issue of family planning, mm-hmm, as one of the strategies. Because without the pregnancy, as we had in the first panel, there will be no maternal death. So that strategy alone, especially for where women, the unmet need is high. We know that the unmet need is high, but they're not having that access to family planning. I think that should be one of the strategies that we should look at and do it now. Mm-hmm. There's no even question of balancing, but we need to do it now. And the other issue I'm looking at is the issue of, in most of these countries, high-burden countries, you see that there's a high adolescent birth rate. Mm-hmm. So the issue of providing sexual and reproductive health information, mm-hmm, and services to young people is a must, and we have to do it now. That one we cannot even say whether we can choose or not. Is something that we need to do and focus on now. And as I've said, the issue of disparities between the poor and the rich, between urban and rural, those that have been left out, governments need to take deliberate decision at this particular time and address those inequalities. Because if we don't address them now, it means they will still bring us backwards. Mm-hmm. Whether we do all these things and then we focus in the urban area and leave the rural ones behind, will not make any difference. It will still bring us down. So I'm thinking that those are the first strategies that we may need to look at the meantime, including issues of quality of care. We really need to improve quality of care, mm-hmm, because without that, then we may not make any difference. But in terms of the balance of digital strategies, what we may not need to look at earlier on is the issue of the political leadership and healthcare financing, mm-hmm, because maybe some government may not be able to totally finance maternal health services as of now. I know most of the resources are from developing partners. So those are the strategies that we need to advocate more. It will be done, but we need to advocate more and discuss more with the government so that those strategies can be implemented. The other issue is what Adres already mentioned, the issue of girls' education. Mm-hmm. Those are the strategies that we need to look at later on. Thank you.
Great, this is really wonderful, and I think you've sort of evoked that idea of the obstetric transition that you have to start in the beginning with dealing with very high fertility is an issue, infrastructure, girls' education, and then you keep going without. So somebody once said to me that most or questions, the answer to them is really and. So it's not one or the other, it's really and both the proximal and the distal. What would you say, just to wrap that up, are the most important next action steps for maternal newborn health system strengthening in Ethiopia? Just briefly, just in a minute or so.
Okay. As I said, for me, Ethiopia, I think, is in the right track, because they already have a health sector transformation plan for the next 5 years. And now, because they have the infrastructure and they have the human resource, the focus is on improving the quality of care. And there's a lot that is being done in the area of improving the quality of care. They have even put a directorate now for quality of care. And we are also very lucky that Ethiopia is one of the 9 countries that are in the quality improvement initiative on maternal and child health. So there's a lot that is being done in the area of quality improvement, including in the area of respect for maternity care, so that at least women who come to the facility, they receive the care with respect and dignity, using the human rights approach and also using the patient care charter. So that is the focus that we are looking at now, and also enforcing on the issue of maternal death surveillance and response, so that we are really sure why are the women dying in the facility, what are the causes of death, and then we can focus more on those issues. Thank you.
Great, thank you for that great roadmap. I think I'll just keep sitting, but I want to introduce our next panelist. Dr. Marianne Etiebet is the Executive Director of Merck for Mothers. That's Merck's 10-year, $500 million initiative to create a world where no woman dies giving life, which would be Address's dream. Working with over 90 partners in more than 30 countries, Merck for Mothers has improved access to quality maternity care services and modern contraception. And as Executive Director of Merck for Mothers, Dr. Etiebet is responsible for successfully implementing a robust set of innovative maternal health programs and high-impact partnerships that integrate the private sector's invention and expertise to design, deploy, and scale solutions that empower women, equip health providers, and strengthen health systems. Her work in international health includes serving as a senior technical advisor of the Institute of Human Virology, Nigeria, which was a PEPFAR implementing partner, while she was assistant professor in the Division of Infectious Diseases at the University of Maryland School of Medicine. So welcome, Dr. Etiebet.
Thank you, Rima. I think I need a shorter bio.
That was only half.
But it's really an honor to be here today with all of you maternal health leaders and champions. And I think it's apt, that we are celebrating the 30 years of gains. We have reduced the maternal mortality rate by 44% between 1990 and 2015. But I want to challenge us to think about the audacious goal that we've set for ourselves for the 2030 Sustainable Development Goal. And if we continue to do what we've been doing, are we really going to hit that goal? And are we going to have a world where no woman dies giving life? Address asked us to look to the future. I have the distinction of coming from one of the countries, Nigeria, where there's not only a very high maternal mortality rate in the 500s, but it's been going up. I also currently live in a country, the United States, where despite our huge GDP, our maternal mortality rate is also going up. And I think that we cannot ignore the fact that we are not on the trajectory to hit 2030 goals. We also cannot ignore the fact that there are some countries, 2 I've mentioned, where we're actually going backwards, not forwards. And you also mentioned that we also need to be cognizant of the disparities within country. My brother-in-law lost his wife to preeclampsia, although they were not aware of their diagnosis. They were not told what it was. This was a hospital in New York City. And this happened about 28 years ago. They immigrated from Nigeria thinking, they were coming to a country where they would be able to access high-quality care. The daughter that was left behind, she asks, why did that happen? I actually can't tell her that she is at a greater risk of dying in pregnancy and childbirth than her mother. In New York City, African American women are now 12 times more likely to die. And I think, there was a comment from Black Lives Matter around we need to really address what those underlying social determinants of health are and think about, again, doing things differently. I'd like to spend part of the time I have here to talk about how I think bringing private sector to the table is a way of doing things differently, and maybe that's a way that we can actually create that world where we hit that Sustainable Development Goal target. So necessity is the mother of invention. Merck invented Merck for Mothers back in 2011, specifically, as Adres mentioned, to create this world where no woman has to die giving life. And, I talk about doing things differently because we don't just fund initiatives that we hope will result in those better outcomes, but we also bring our expertise, our experience, our Merck employees into this work so that, we think, that may be a secret sauce, a secret ingredient that will actually get to that outcome. The two things we focus on, quality of care, many of the panelists have mentioned it, and modern contraception, and spend a lot of time in the first panel talking about how that is a critical intervention in terms of reducing the global maternal mortality burden. And as I mentioned, I do want to spend some time just thinking about sharing with you some specific examples around how we think, that private sector perspective, can help us think differently about how we do things. One phenomenon that I have noticed, I think we all have, there are lots of, we talk about innovation. And we're all excited about new innovations, the shiny new objects that are actually going to, kind of drastically change how we do things and what the outcomes are. But we all know that it's very difficult to actually embed innovations in routine quality of care or routine care. And that many innovations do not become, what our goal should be, those shiny new normals that are actually going to help us reduce the knowledge due gap and get those innovations to bedside and to have impact for women. And so I think, our experience in Project Champion, which is a partnership with the WHO and Ferring Pharmaceuticals through phase 3 clinical trials to understand if a heat-stable carbetocin it will be non-inferior to the current oxytocin, gold standard for postpartum hemorrhage. Once that happens, are we actually going to get it to the bedside? How are we going to get it to market? Will this product be registered in the countries where it's needed? Will it be pre-qualified? Will it be part of guidelines? Will it be part of essential medicine list? Will midwives be trained on how to use it? These are all things that we need to be thinking about, and we need to actually invest in doing in order to bring innovations to women. The second example I want to share, we heard a lot again, Anne, talked about contraception. I think we all recognize that getting contraception onto the shelves is necessary but not sufficient. And one of the things that we need to do is to figure out how it is that even though it's necessary but not sufficient, women are spending days, hours, money getting to district health facilities, looking for their contraception of choice, it not being there. And so think about what impact that is having on their behavior, on their decision making. And so again, in a partnership with the Gates Foundation, IntraHealth, and the government of Senegal, we integrated local private providers in the public sector distribution chain so that there were less than 2% stockouts. We've been able to maintain that performance level for over 47 months now. But the most exciting thing about this particular partnership is that it's now owned by the government of Senegal. But Merck experts were involved in this project. They developed sustainability costing models that were able to prove that this could be something the government could afford, and that this could be something that would be sustainable. So, we think of that as the first point that I made about the erosion of our gains. I think we all have the experience in many projects that we work on, that when we remove ourselves from the project, when we stop funding, those gains that were achieved also erode. So I think it's going to be very important for us to think about sustainability and making sure that the performance gains that we're involved in remain after we leave. The last point I want to make around private sector involvement is we cannot just think about private sector at the global level. We need to think about private sector at the local level. 40% of women in low and middle income countries actually seek care, critical antenatal care, critical labor and delivery care from local private providers. And this includes women at the bottom of the pyramid, where there's an even increased risk of receiving low quality care. And so in order to take care of these women, we can't ignore this sector. And I want to share with you some of the work we are doing with local private providers to ensure that women who are receiving care there receive the highest quality care. So in India, in partnership with JPIGO and FOGSCI, which is the National Society for Obstetrics and Gynecologists there, we've worked to train multidisciplinary care teams to achieve certain clinical standards that have been endorsed by the society and also reflect the WHO standards. We haven't stopped there because, again, we can't just do this in small pockets. We need to scale. So how do we scale? We do that by partnering with local institutions, key among them the professional society. And now we're in the midst of seeing how we can do that in 3 states in India. And then the last point that I'd mentioned before, how do we sustain? And I think one of the things around sustainability is who's going to pay for quality. Someone has to pay for it. That is, whether that's government, whether that's insurance companies, whether that's women who are actually voting, paying with their feet. And, how do we actually create platforms where they recognize what is good quality and they're able to actually share with communities what good quality looks like, and, as I said, drive utilization to those providers. I think I was talking with Mary Ellen, before we came up here, and, she talked about the promise, of accreditation, but also the peril, in the sense that accreditation itself is not necessary. Again, it's not sufficient. Yeah, we need to invest in these multidisciplinary care teams, in their ability to have professional development, develop their skills, be able to speak up. One of the things that stayed with me after visiting one of these sites was a untrained worker as part of the team. By participating in this QI work, she had the space and she was empowered to say to the consultant, actually, we missed a step. Yeah. And that QI process empowered her to be able to say that and had changes in terms of how the team worked. So I do think that, as we do all of this work, at the heart of it, it's midwives, it's, our nurses, it's our doctors, it's our families, that are taking care of women. And unless we invest in them and we listen to them and we create those platforms where their input is integrated in solutions, we're not going to have, we're not going to hit our goals. I couldn't end without saying a little something about midwives. The point I want to make here is that, again, when we invest in women, we're not just investing in health outcomes, we're also investing in communities. And so many midwives, at least the ones that we have worked with in terms of from the local private provider sector, also, they own their businesses. And you mentioned one of the things that they think about is, where are my children going to go to school? But they're also thinking about, how do I grow my business? And I think, when we, part of the work that we did with them through our partners, PSI and PACE, was not just training around clinical standards, but training around how to build capacity, to grow their businesses. I want to end. I was on a panel earlier with Claudia Colon, who is a colleague from Saving Mothers Giving Life partnership that we have with USAID. And she said, ideas without funding are a hallucination. And I wanted to share that with you because, one, it's very funny. But two, it's somebody has to pay for it, yeah? And so one of the things that we think about is, how do we leverage private capital and private investments for maternal health? And just last week, we launched a development impact bond with USAID, USB Foundation, implementing partners like PSI, to make sure we could leverage private capital and bring that to bear for these maternal health goals. Because I think without bringing the private sector into the mix, I don't actually believe that we're going to get to where it is that we need to. So thank you for your time.
Thanks, Marianne. Yeah, that was a very broad look at all of the different things that Merck has been doing, and I'm just going to ask you one quick question. So you've highlighted very well the role that private sector innovation can play in spurring technological improvements and system efficiencies, as well as the very important role that you ended up with about how donor support can and financing can play a role in improving access and quality of care. So looking forward from your perspective, and it's exciting to have you at Merck for Mothers, what do you hope for? What are the best things that you hope for from private sector investment in global maternal newborn health in the next 15 years? And what is one possible caution that should be exercised with regard to private sector healthcare in maternal newborn health in low and middle income countries?
Thank you. So I do think there has been a shift in the dynamic around partnerships with private sector. I think definitely within the last 30 years, but I think even within the last 2 or 3 years, there's been a real acceleration of how private sector are thought about not as the problem, but as part of the solution. And I think that has been because, there are great examples of how private sector has been able to demonstrate value in this space. And again, one of the things that I strongly believe around that demonstrating value is by bringing the private sector focus on scale, on sustainability, on resiliency, on growth, on listening to consumers, all of those things that I do believe will be instrumental to getting to that SDG target. The second part of the question was around, what are some of the things that we need to be careful about? I talked about the distinction between the global private sector and the local private providers. I do think that we need to make sure that those 40% of women who are receiving care in local private sector are receiving high quality care, and especially those women who are at the bottom of the pyramid. And so, working with partners to advance that and to raise awareness of that, I think is something that, all of us can participate in.
Great, thank you so much. So the next and last panelist really needs no introduction, but I'm going to do my best. Mary Ellen Stanton is a senior maternal health advisor at the U.S. Agency for International Development, where she guides the Global Health Bureau's maternal health portfolio, including research and implementation of country programs to end preventable maternal mortality. She's the team leader for maternal health in the Division of Maternal Newborn Health, serves as the USAID Washington-based coordinator for the Afghanistan Health Program for the Bureau of Global Health, and co-manages USAID's obstetric fistula program. She's helped develop USAID's advocacy and implementation research activities to address the problem of disrespect and abuse of women during childbirth in healthcare facilities. And she is a friend, mentor, staunch supporter, influencer, and champion. So with that, our Mary Ellen.
Good afternoon, everyone. It really is an honor to be here, and so wonderful to be with so many old friends and always meeting new people. And thank you for your staying power here on this afternoon. Late on Friday afternoon, I know. I think that in over the 30 years, I see that we have had an evolution in how we frame the issue of maternal mortality and survival to ourselves and also to the world of politics and policy. At first, it seems it was largely an issue of health and health care, family planning and maternity care, but with a clear understanding of the need for what they called for at the time alarm and transport, referrals, and attention to girls' education and prevention of early marriage. Currently, I think we have a growing attention to human rights, a stronger appreciation of maternal survival truly as a gender issue. And this is highlighted in the new EPMM strategy. Women needed to be treated with respect and never discriminated against because they are from a stigmatized group, nor neglected, detained, shaken down for payments, humiliated, or treated cruelly. Childbearing women have rights to privacy, confidentiality, and to make decisions about their care, including whether they have a C-section or an episiotomy. So we have health and we have human rights. I think that from a USAID perspective, we see that preventable mortality fits squarely in a development lens, profoundly affected by economic growth, governance, education, and infrastructure, to name a few, through which health systems can be strengthened. There will be a day in healthcare facilities where clean water will run from the tap in every one of these facilities, where women will have access to working toilets, where birth and C-sections will be done under electric lights and not under the lights of cell phones. And women will no longer have to share their single bed with another woman or two. My colleague Debbie Armbruster says she sees 5 women sharing a bed. I see this as an evolution of how we understand and frame the issue with decision makers, and very realistic and positive about the real challenges and opportunities that we face. But make no mistake, achieving the ambitious goals for the MDGs is no small undertaking. I think it's actually an enterprise of gigantic proportions. In the period from 2000 to 2015, the annual global rate of reduction of maternal mortality was 3% annually. It, of course, varied by countries. New calculations show that progress will be needed to be accelerated substantially, likely more than double the rate in which we saw in the last 15 years. Think about it. Maintaining momentum is not going to be enough. We are going to have to do more. On this slide, it displays 25 low and middle income, high burden countries where USAID focuses its support for maternal child health. The horizontal axis displays the historical rate of reduction, and the vertical axis, the annual rate of reduction needed to achieve the maternal mortality MDG. The size of the circles indicate the number of maternal deaths annually, and the darker the colors, the higher the maternal mortality ratios. The circles are concentrated to the left, showing lowest progress in the far left there, Yemen, and highest on the far right in Rwanda. These are, again, these 25 selected countries that we work most intensively. The concentration of the countries in the upper left quadrant displays that the vast majority of the 25 high-burden countries, all but which are located mostly in sub-Saharan Africa and South and Southeast Asia, they need to dramatically increase progress, significantly beyond the gains of, that we achieved by 2015. Certainly, this is going to require renewed commitment and better strategies and commitment to the action that it will take to influence them. As I prepared for today, I thought, oh, I'd tackle some of the trends and challenges and opportunities facing us. It is a changing landscape. And some of the many factors that include economic growth, increased use of services largely, but not only triggered by financial incentives, privatization, decentralization, urbanization, medicalization, including the cesarean section epidemic, inequity, conflict, migration, innovations, including new technologies and new tools, commodities, partnerships, the data revolution, governance and financing, disease outbreaks, growing attention to non-communicable diseases, the amplification of citizens' voices, and the growing attention to empowerment, equity, respect, and dignity. The list is incomplete. So obviously I couldn't take on all of those. It became clear to me that some of these forces are going to profoundly affect what happens in countries and what we can do. And Margaret Kruk and her colleagues wrote very eloquently on this. And one of the papers in the most recent Maternal Lancet series on external shocks. For much of this, it would seem these are positive things that are happening. But actually, there can be unintended, detrimental, or even perverse consequences to financial incentives, to decentralization. Just moving more women into services, that's good, right? A good opportunity to provide life-saving care. But maybe it's bad because it's overwhelming these facilities with women who could have a normal birth, and the women with the complications that they have or emerge will not be seen, and the problem's not even noticed. I can't forget the pivotal publication by Lynn Friedman, who wrote some years ago an important book called Who's Got the Power? And highlighted the imbalances in gender, race, and class, and this was brought up by a questioner in the last panel, that affect access to and provision of services. So I will take up just a couple of topics. recently, very recently, the Bangladesh Maternal Mortality and Healthcare Survey 2016 was released. The survey finds that an estimated maternal mortality is 196 per 100,000 live births. Sounds kind of familiar. Do I have it wrong? Actually, it is essentially unchanged since 2010. That must have been an incredible shock to them. It was to me when it came across my desk. The plateauing of reduction of maternal mortality ratio is sobering enough, but perplexing when more women are accessing maternity care than ever before. In Bangladesh, half the women now have births attended by medically trained provider, a rise of from 20%, 7% in 2010. Facility deliveries are increasing at a rate of 4% per year, and positively, there has been a steadily declining inequity between rich and poor. Deliveries by C-section increased from 12% to 31% in the past 6 years. So why are more women not surviving childbirth in Bangladesh? After a really dramatic slide coming up into 2010. Certainly there are going to be a lot of analyses of the reasons for this, and I'm sure many here will jump to quality of care, which I'm sure is part of, but there's going to be other things that are part of the picture. I should note that Bangladesh is not the only country that's reckoning with plateauing of MNRs, and you brought up Nigeria and the US of increasing MMRs. So, I don't know where I am with the slides. Oh, right where I wanted to be. Because, yeah, almost done? End. Oh, okay. The case of Bangladesh. The right hand where that arrow is, that high C-section rate, it's a different data set, but the thin bar over the heavy bar is showing the difference between rural and urban. There's a lot of variability. It's higher in Africa, higher in Asia in C-section rates than in Africa. But this continuing increase in major surgery, much of it not medically indicated, is posing a threat for women. They are undergoing major surgery that has anesthesia, infection complications, and can cause iatrogenic fistula. So we need to move to right use of C-section. I think one of the most important mantras from the Maternal Health Lancet series was exactly what that slide brings into this. Too soon, too much, too soon, too little, too late. All women need access to life-saving care and quality care, and some are getting too much, which is putting them at risk, costing a huge amount of money. I was going to talk a lot about my human resources, but my time is up. What I want to say is to reinforce what you have said here so eloquently, Address, that the need to pay attention to the providers and really understand their situation of where they live, the importance of the career ladder, and the ability to educate their children, be with their families. In conclusion, do I have time for the conclusion? At what should be the most joyous time in a woman's life, women should not have to fear death. Rather, all women should expect to give birth to a live-born baby who survives and thrives, and women themselves to survive without catastrophic consequences, such as mental trauma and even obstetric fistula. Despite the progress, it is heartbreaking and unconscionable that 53 million women are not receiving childbirth care at all, and 300,000 women still die of maternal causes each year. Furthermore, the disparity between the rich and poor nations is staggering and intolerable. The lifetime risk of dying of pregnancy-related complications in sub-Saharan Africa is 100 times more than it is in the United States. We do look forward to a world where a woman's country does not determine her risk of death related to pregnancy, and that preventable maternal mortality comes to an end. It doesn't hurt to mention Mahmoud Fatah's important charge to all of us yet again this afternoon. Women are not dying of diseases we cannot treat. They are dying because societies have yet to make the decision that their lives are worth saving. Thank you.
Okay, 10 minutes for the whole thing, right? Okay. Okay, so I have one question for you, Mary Ellen, because and I want to open it up to the floor. I've asked enough questions, but you described very well gains and losses, you know, one step forward and a few steps back. And I think what you pointed out is that there's a lot of work to be done and that it's shifting. So we've made some progress, but we've lost some ground. And we're at risk that it might end up being a wash at 30 years and not the kind of wash we need, right? So I would like to end on an up note. So I want to ask you, what do you think, with all this shifting ground and the progress and and some of the risks, what are the greatest opportunities afforded to us at this very particular moment in time where we find ourselves to move forward the dial on safe motherhood and to end preventable maternal and newborn deaths by 2030, and stillbirths, I should say?
Well, there are many. Let me pick two. One is we really haven't talked very much about research and data and so forth this afternoon. But I think that the world really is changing. We are getting data now through HMIS systems that we wouldn't have thought of before. It's nowhere near it needs to be. We have rich data sets from surveys and so forth, and from experimental work in interventions and so forth. So we have so much to learn. Mm-hmm. And I think we need to be looking locally, nationally, and internationally about what is working and get rid of our long-held personal beliefs about what is best and be open to new things. And the second thing, it has been mentioned over and over again, this can't be done without funding. And we know when we look at a global level that donors' contribution to what's going down is the traditional donors, the bilateral donors, and so forth, with respect to the whole pool, is getting less and less. That's the reality. But built on the back of economic growth, we have domestic resource mobilization. Countries are putting in more. They're starting to put their money where their mouth is. And we have private sector, all kinds of private sector engagement. I hope that we can lessen the money that's coming out of pockets of families. They're putting themselves at risk. They're putting in a great deal, sometimes the major proportion of the cost for care, which isn't always good enough for them. But I think overall we have a shifting pie. I remember Anthony Costello years ago was at WHO. and we were talking about money to do something. Oh, we were talking about $50 million or something like that. And he said, where are the zeros? I think with things like the Global Financing Facility, we will have to see. But we need to keep pushing in that account. And the door is opening, so we have to keep it open and open it wider.
Thank you. I think I'd just like to end by saying, adding maybe one thing to what you've said, which I think is really important, the research and the funding, but to draw back in from the previous panel a little bit, is that it feels like a watershed moment also for women's voices. I mean, in this country, there is this incredible tipping point of women coming forward and standing up and saying, "Me too," and I, I'm not afraid to talk about it, and I want something different. And I think if that spreads throughout the world, and that might be in addition to it's a little bit what Adra said. We need the human resources, we need the infrastructure, and we need the demand and the entitlement and that social justice lens. And I think we're hopefully at a tipping point for women's voices to stand up and put an end to this, because there is an unfinished agenda and a long way to go. So it's been a wonderful panel. I have questions if others don't, but I really want to open it up to the floor because I'm sure that you have questions. Yeah, and so I think I'll just open it up for question and answers now.
I'm sorry, I don't ever know now how to ask questions. So you brought up C-sections, which is really important. And I do think it's something that ties kind of the work here in the United States. And for us at the Black Mamas Matter Alliance, it's also a matter of respect, bodily autonomy, value. If you're not allowed to VBAC because you are poor or Black or in a rural community, that's about respect and abuse, and that carries globally, right? And so when you're thinking about building in other communities and other countries, if you build upon a model, an OBGYN model like me, you're going to get more C-sections versus a midwifery model. How do we have that language resonate here in the United States, but also globally around how C-sections also are part of this kind of disrespect and abuse?
I'm sure everybody here could contribute to this provocative question. I will say that work through groups like your group, the White Ribbon Alliance, raising this up as, to be straightforward, women should not be bullied into things. And part of it is going to be well-meaning providers starting to understand that that's what they're doing to clear the beds, and women themselves learning how to talk with the healthcare providers. That's just a start at what I'm sure is a long discussion.
Would somebody else like to comment on the issues around cesarean section and women's empowerment or respect and respectful care? I think that was the nature of the question, yeah.
I think women also need to be informed. When they are coming for antenatal care, they have to receive adequate information. Because I know that mostly it is in the private hospitals where women are just told you need to go for cesarean section. But if they have enough information, they know the progress of labor, they know what to expect during labor, then they will be able to make that decision and agree with the doctor when they really understand that things are not okay. Yeah, I know I had an experience, not on cesarean section apparently, but I was visiting a gynecologist because of one problem or another, and then she said, "How old are you?" And then I told him my years, and then he said, "Oh, but you don't need your uterus. Why are you keeping your uterus? I need to remove it." And then I said, "No, I don't have any problem with that. Why should you remove my uterus?" It's because I was informed. If it was a woman from the village, probably she would have said, "Oh, okay, go ahead and do it." So once we give them adequate information and they understand the issues, they'll be able to make the decisions.
Anyone else? I would say I would be happy to just say something. I was struck in the beginning when Barbara started talking about the sort of history and starting with the road to death of Mrs. X, and the things that were highlighted there were community services very close to women and decision-making power for women and focus on socioeconomic status and geographic isolation. And then as we went forward into the paradigm shifts, you see this shift into all women are at risk and institutional delivery for all. And I think that to the speaker's question, what it highlights is a medicalization, and that you said it very well. It's a model and a thinking. And I think in the global strategy now for every woman, child, and adolescent's health is, again, trying to bring back in not just survive, but thrive and transform. And so that we're not thinking just about the medical aspects of maternal health, but also the social aspects and the transformative power of the human right to the highest achievable, attainable level of health. So anyway, there's a lot of hands up. So anybody want another question? Looks like Betsy.
Thanks. Thanks very much, everyone, for the really great panel. I have two questions, maybe aimed at Adris and Marianne primarily. In terms of the pathway around midwifery, and agree with everything that you said. One thing that I also see, though, is even a step before the training and the retention, all the pieces, is the incentive to go into midwifery as a career. Mm-hmm. And I think you spoke and about that career pathway and midwifery leaders, which I think is so critical for young people to be able to see that. But we found in a lot of countries that isn't the case, that isn't there. You ask young people what is a midwife, who is a midwife, and it's not a very flattering picture of what comes back. So, what are your ideas around that and how you raise up the value of the profession of itself? And are there opportunities with the private sector in talking about, the formidable marketing kind of, skills and strategies in private sector and thinking about that?
Great question.
And the second question is also on the private sector. So, as you said, Marianne, a lot of times the private sector is talked about as just a thing, right? And there's a huge, are we talking about a Fortune 500 multinational company or, the midwife who's hung her shingle out. But in between there as well is something I think we don't talk about very much, which is more local, corporations, businesses, et cetera. And we certainly hear all the time from NGO and civil society partners, they don't really know how to think about partnership. So if you could just share some ideas on how we can help to make those, that's happening more at the global level, as you said, and how can we be helping to kind of foster those partnerships?
Excellent questions. Adris, I think you're up first.
Yeah, I think a very good question. For me, it's really raising the profile of midwifery. And I think that hasn't happened well. I think many people look at midwifery like, well, what next? Perhaps you are there on the bedside. Actually, the reason I took the job I'm doing now is to show the world, not only Africa, that you can actually be a midwife and also be a leader. So in Africa, actually, you cannot find a midwife leading a university, and I'm doing that. I applied for this job to show everyone that a midwife is a leader, and you can actually lead anywhere. So although I still do my midwifery work, and that's why I'm here, but just taking that pathway, I was trying to create an opportunity for young people that are out there thinking, okay, I can be on the bedside, I can work in the rural area, what else can I do? But also within the health sector, there should be opportunities for midwives to lead, because I think the issue about leadership is a critical issue for young ones. So in Malawi now, I think most of you know Fanny Kachare, who is my doctoral student, but is the director of reproductive health in Malawi. It's been a battle. Because nobody believed a midwife can actually take that role. Now she influences policy, she influences practice, she influences education. If we start doing that, then the profile of the profession goes up, rather than just leaving everybody on the bedside. So we need to keep other midwives on the bedside, but also recognize them. So I have a student, Sarah, who finished her master's degree in midwifery, but was a midwife on the ward, not even a matron. So in Malawi, you're a matron, you are in charge of everything. This midwife was literally sitting on the labor ward. And that's what you need to do. So let's have this, let's penetrate the system. And of course, my student, Juliana Longozo, who is now a member of parliament, and I know she aspires to be a minister. But to me, when Juliana says, I'm a midwife, and then she has this voice in parliament, she's really, looking at issues, not just as a midwife, but as someone who understands the healthcare system. So I think we need to start breaking, because there are times when midwives want to talk to themselves, and we're happy, we're ICM, we're in meetings. We need to move out of that, I think, that comfort zone and start penetrating. Let's get on the table, not just sitting on the table. We need to be part of that menu so that we can say what we think midwives need. But I also don't believe that we should just be looking in this way, like everything is about a midwife. A midwife on their own cannot make a difference. Mm-hmm. You need other health professionals. And I think that also type of thinking is what we need looking forward. Thank you.
Anybody else want to add something? That's right. I have one thing I would add, and that is that the WHO report on midwives' voices, midwives' reality, really points out, I think Betsy's point is well taken, that the conditions under which midwives work in many, many places make it hard to want to sign up, and that we need to ensure that midwives work in environments that are decent. That's the bottom level, decent. So any self-respecting person would say, I sign up for that as a career, and I'll put my family in that position. It's unacceptable to have midwives working in conditions that are so deplorable, because who would want to sign up? And we know how many we need. It's been pointed out. So,
and maybe just one addition, remuneration. Many African countries, midwives are lowly paid. Now, we need to advocate for better pay, and I think we have that responsibility, and really not to fear to talk about it. So I can talk to our head of state and say, you need to pay midwives better. And I don't know how long it will take, but I'm still optimistic. Perhaps one day we can actually be, a profession that's, well paying, because the young ones, the reason my daughter chose medicine was like, Mom, how much were you paid? And she opted for medicine because she'll finish, she get a house, and career progression is good. That's why I have a responsibility to help the profession in my own country. So this whole career pathway, postgraduate programs, the idea is that once people start getting this, then they will have that voice. I know that time is not on our side, but one issue I can share with you is that when you sit in a meeting and you don't have the qualification that people think they can respect, they will not listen to you. Mm-hmm. And it's happened to me, like you say something and nobody, notes. And somebody speaks and they say, just as he said. And I don't like that. I don't think the profession, we should reach to a point where when a midwife speaks, then people listen. Mm-hmm. And that's what can change the profession. Mm-hmm. Thank you. Sorry.
Thank you. Okay. Marianne, I want to turn back to you.
Sure.
So very good question.
Yeah, no, thank you, Betsy, and you're exactly right. That third kind of category of private sector engagement is at the national level with local businesses. And I think there are three ways I'd like to answer that question. I was struck during your presentation, your slide on multi-sectoral collaboration, and you talked about the impact of nutrition for health. I think we also need to be careful when we use these words, because sometimes people use multi-sectoral to mean private versus public, but multi-sectoral, is also used to talk about other sectors and how they impact health. Mm-hmm. So it's not just the health system for health, but other systems for health: transport, education, nutrition, power, sanitation, all of those things. So I think that actually the SDG framework really helps give local businesses a way to think about how their contributions can directly impact health outcomes, maternal health outcomes. And we should do more to bring them into that conversation and actually be very specific about how their contributions are not just indirect, indirectly associated with some of these things, but are directly associated and drive maternal mortality. So that's kind of the first way I think that there's an opportunity we have not fully capitalized on. I think the second way around including local businesses is their roles as employers. They're employing millions of women. So what are they doing around employee health, around population health? How is it that we can talk with them, to integrate what we know works to improve the lives of women and to invest in health of women that we know has, dividends with, economic gains, economic growth, et cetera. And I think the third part is really partnerships between local businesses and local civil society. Because I think if we can have real partnerships there, they can hold government accountable. And they can hold government accountable for a number of things, including making sure that the governance systems, that will allow all of this work to thrive and sustain exist. So, those are some of the things that I think about in terms of opportunities, we haven't capitalized on yet.
Mm-hmm. Mm-hmm. Good question. I was going to ask you, one of the questions I had for Marianne, if we'd had more time, was what we found during the EPMM work to try to develop indicators for some of these questions, that there's no way to measure intersectoral collaboration or multisectoral collaboration. We don't even have a good working definition for what you've just, defined it in a variety of ways. Mm-hmm. And it's such a buzzword. We all talk about it. But if we don't even know what we're talking about or how to track the progress toward it, I think that's really a gap. Other questions? I think that might be it. Yeah? Is it to me to close? Or you're going to close? You. Mm-hmm. Go ahead.
Well, thank you all. What an amazing way to spend a Friday afternoon. Thank you so much for all the panelists and the moderators. Let's give them another round of applause. Thank you. So there was a lot of information shared today, and including PowerPoints. They will all be available on our website on Monday. So please come back to the website. There'll also be a webcast that you'll be able to see, and eventually there will be a summary. So we will keep coming back to these discussions. For right now, there is a reception out in the foyer, and we can be out there, we can be jolly, and we can be loud, and we can celebrate the 30th anniversary of the Safe Motherhood Initiative. Thank you so much for coming today.
Thank you.
Thank you.